Lifestyle medicine for COVID-19 and NCD care, a wake-up call. This event is proudly supported by the Lifestyle Medicine Global Alliance, the American College of Lifestyle Medicine, the International Board of Lifestyle Medicine, the Department of Health, and the Philippine Medical Association. The Philippine College of Lifestyle Medicine is also supported by several institutions pioneering lifestyle medicine practice in the country. The Remnant Institute Incorporated, a center for lifestyle medicine and education. The Adventist Medical Center, the Four Leaf Lifestyle Medical Group Corporation, the Plated Prescriptions, and the Culinary MD. This event is also made possible through the help of our sponsors, the Pascual Pharma Corporation, the Omron, the Taisho Pharmaceutical. Simply
When accuracy becomes embedded in technology, when medical becomes personal, when life presents zero compromises, that's the sign of the future of healthcare, a future with Omron. Omron is devoted in creating innovative products and services for the benefit of everyone's health, opening possibilities in health management that can be integrated in everyday life. For decades, Omron has made blood pressure measurement at home accessible, designing each device with unique vital sensing technology and rich clinical data to provide the best quality on a global basis. Omron's range of products help people lead healthy and secure lives, conveniently sized, precisely fit, and accurately detecting, whether you're at home or out and about. Omron's state-of-the-art products makes health management easy. They allow people to live a life of zero events, a life with reduced incidence of diseases caused by high blood pressure. Omron has led the advancement of blood pressure monitoring, penetrating the global market as a competitive brand that assures quality and accuracy. Though it took more than 35 years before the first 100 million units of Omron blood pressure monitors to be sold worldwide, 200 million units were sold by 2016, showing how Omron Healthcare have been rapidly penetrating the global market. Compelled to forge a healthy future for individuals, Omron's monitoring devices are easy to use yet medically accurate, which is why Omron's monitoring devices are likely recommended by doctors here in the Philippines and in various regions. Omron knows the importance of detecting hypertension in its earliest. That is why Omron's blood pressure monitors for home use are designed with innovative features from precise feed cuffs, advanced accuracy technology, to Bluetooth data accumulation. Everybody can monitor their heart health efficiently and know when to be aided medically. Accessibility, quality, accuracy. These are the qualities why Omron's blood pressure monitors are validated by the Philippine Society for Hypertension, showing outstanding results for both past and present models. Omron is available within reach, so everybody can take charge of monitoring their heart health. Everyone can now look forward to a future of personal health management, a future when medical technology has reliable accuracy, a future when medical assistance is just a tap away, a future when life has zero events, zero compromises. This is the Omron future. This is Omron Healthcare.
Dr. Manuel Gayoles obtained his medical degree at the University of Santo Tomas and pursued his residency in physical medicine and rehabilitation at the University of Santo Tomas Hospital. He was the former dean of the College of Physical Therapy at the St. Paul University, Iloilo. He is a chairperson at the Bacolod Adventist Medical Center, the Bacolod Our Lady of Mercy Specialists Hospital, the Riverside Medical Center, as well as at the Corazon Locsin Montalibano Memorial Regional Hospital. He also practices at the Department of Physical and Rehabilitation Medicine at the Doctors Hospital Bacolod, the South Bacolod General Hospital, and the Metro Bacolod Hospital and Medical Center. Dr. Manuel Gayoles is a diplomate of the International Board of Lifestyle Medicine and a member of the Philippine Board of Lifestyle Medicine. Kindly give your undivided attention to Dr. Manuel Gayoles as he talks about exercise prescription for COVID-19 in special conditions.
Good afternoon. The topic that we will be taking up today will be the topic on physical activity exercise prescription for COVID-19 cases and special conditions. Over 2 millennia ago, the benefits of physical activity has been recognized, and Hippocrates says that if used in moderation and exercised in labors to which each is accustomed, bodily parts become thereby healthy, well-developed, and age slowly. And if the opposite is done, meaning inactivity is done, they become defective in growth and age quickly. Physical activity means bodily movement or muscular contraction that causes energy expenditure beyond its baseline. By baseline here we mean 1 kilocalorie per kilogram hour, which is equivalent to 1 met. And if we translate that to a basic activity, if a person is sitting quietly, that would make him spend 1 met. Exercise means purposeful physical activity that is organized, planned, and recurring, and that is done with the intent of improving and maintaining one's health. Fitness, on the other hand, is the ability to perform one's activity of daily living, respond to emergencies, and enjoy leisurely activities with sufficient energy, vitality, and without excess fatigue. Fitness is actually the goal of physical activity and exercise. Plato mentioned that lack of activity destroys the good condition of every human being, while movement and methodical physical exercise save it and preserve it. In lifestyle medicine, of course, exercise is essential, but a good diet, sleep, and avoidance of hazardous habits can also improve a person's well-being. The world global causes of death, as given by the Global Health Estimates of the World Health Organization in 2018, states that the top causes of mortality in 2000 and 2016 are not that dissimilar. It's still ischemic heart disease is the number 1 cause of death, stroke. The rest, or the non-italicized or colored items, are largely infectious in nature, COPD, trachea bronchus lung disease, which are all associated with lifestyle conditions. In the Philippines, the leading cause of mortality is similar. The DOH, in its latest data, which was dated about 2013, stated that heart disease, disease of the vascular system, malignant neoplasms, which would include lung cancer, COPD, diabetes mellitus, and kidney disease are the most common cause of death. If you again are able to tie all of these conditions, by and large, all of them are associated with lifestyle conditions. The latest census in COVID incidence and mortality as of August 24 is this. You have a mortality rate of 32,264. Percentage of those who have recovered is 91.4, or 1,709,624. And the percent that is at the moment, at that time, active is 127,703. Now, the whole case of COVID in the Philippines is more than 1.5 million, or so almost 2 million, which is 1.869 million. Now, what does sedentary lifestyle do? Well, if a person is sedentary, they will have mental health issues, risk of developing diabetes, uncontrolled hypertension, obesity, and weight increase, which are also associated with other forms of morbidity and also cancer, increase of developing poor sleeping patterns, heart disease, lack of energy, and increased risk for hypertension. What are the benefits of exercise with regards to or in connection to the management of diabetes? Exercise reduces the incidence of diabetes by approximately 50%. Physical activity causes increased glucose uptake into the muscle, balanced by hepatic glucose production, with greater reliance on carbohydrate to fuel muscular activity as the intensity increases. So leisurely activity may make you spend less glucose, but the higher the intensity and the longer the duration, you would not only spend glucose, but through gluconeogenesis, you'll also be converting fat to glucose. Factors that influence exercise and fuel use: intensity of physical activity. Any activity that causes shift from predominant reliance to free fatty acid at rest to a blend of fat, glucose, and muscle glycogen with a small contribution of amino acids. And with increasing intensity, there is a greater reliance on carbohydrate as long as sufficient amounts are available in muscle and blood. Duration of physical activity, on the other hand, can cause intramuscular lipid stores to be readily used. That's why in protracted or aerobic exercises, they don't only cause fitness, but it makes you lean because you will also make use of your lipid stores. Glucose production also shifts from hepatic glycogenolysis to enhance gluconeogenesis as the duration increases. When you say gluconeogenesis, this is conversion of glucose from fat and protein stores. And the number one source of gluconeogenesis or glucose from gluconeogenesis during increased exercise duration would be fat. Early exercise can also cause certain mechanisms that would not only make use of our usual physiologic insulin mechanisms. There's such a thing called GLUT4 translocation, which increases the inward flow of glucose into the muscle. In this figure, you will notice that there is a twofold increase of GLUT4 activity and also a 100-fold increase in glucose uptake in the muscle as the exercise intensity and duration is increased. Now, skeletal muscle glucose uptake during exercise is regulated by increased skeletal muscle glucose uptake and coordinated increases in rates of glucose delivery through capillary perfusion and surface membrane glucose transport, which we have mentioned a while ago, the GLUT4, and intracellular substrate flux through glycolysis. The mechanism behind the movement of GLUT4 to the surface membranes and the subsequent increase in transport by muscle contraction is largely unresolved, but it is likely to occur through intracellular signaling involving calmodulin-dependent protein kinase, 5-AMP protein end kinase, and possible proteins kinase C. Now, physical activity can result in acute improvements in systemic insulin lasting from 2 to 72 hours. In this figure, it is illustrated that death risk for men in their 50s who have diabetes is increased as their VO2 max or maximum oxygen consumption decreases. So there's an indirect relationship between the VO2 max or maximum oxygen concentration consumption during exercise and that of the risk for death secondary to diabetes. If you notice in this figure, the higher the VO2 max, the death risk or mortality risk is increased or lessened by 70%. On the other hand, if your VO2 max is less than 24.5, the death risk is highest at 180%. How does VO2 max correlate with cardiovascular disease? Now, this slide is very busy, but if you just look at the colors of the tables, you will notice that in the lowest column, lowest row, which is colored yellow, you have the highest risk for cardiovascular disease. On the other hand, in the light blue row, you have the lowest risk. Now, if you go from top to bottom or from blue to yellow, you will notice that there is a decrease in your VO2 max irrespective of age. So, this figure only says one thing. As you increase your VO2 max or oxygen consumption with higher intensity or increased duration of exercise, your cardiovascular risk or disease risk is significantly lowered. On the other hand, the more inactive you are and the less VO2 max activity you have would give you a higher risk. In fact, studies have shown that sitting or being sedentary in itself or sitting for prolonged periods is in itself a risk factor. Cancer. Now, it has already been proven since 2005 that the mortality and risk of recurrent breast cancer is diminished by 50% with recurrent exercise, or with the exercise, and the lower risk for colon cancer by 60%. But recent studies have shown that there is also strong evidence that higher levels of physical activity are linked to lower risk of several types of cancer, namely bladder cancer, breast cancer, colon cancer, as we have mentioned, endometrial cancer, esophageal cancer, kidney or renal cell cancer, and stomach and gastric cancer. Now, evidence linking physical activity to lower cancer risk are mainly from observational studies. But once you have duplicated these observational studies in different settings, and through years of repeated studies in correlation, you will also or almost always have a chance of a causal relationship between physical activity and the reduction of incidence of cancer. Now, what about lung cancer? It is possible that the difference in the incidence of cancer or lung cancer among individuals who exercise and who don't exercise is largely due to smoking. They found out that among individuals who are smokers or who have quit smoking, those who exercise have a lower tendency to develop lung cancer. But they didn't see this correlation among those individuals who exercise but were not smokers. Meaning, those individuals who exercised and did not smoke have no correlation at all with the lowering of their incidence for lung cancer. Now, however, it is possible that the difference of smoking rather than physical activity are what explain the association of physical activity with reduced risk of lung cancer. In 2006 meta-analysis of 25 observational studies, physical activity was associated with reduced risk of lung cancer among former and current smokers, but was not associated with risk of lung cancer among none or those who never smoked. For other cancers, limited evidence of an association with physical activity is seen in cancers of the blood, as well as cancers of the pancreas, prostate, ovaries, thyroid, liver, and rectum. If we have an oncologist here in the audience, I'm sure all these oncologists would agree with me that the common risk factor for most or all cancers would be smoking. And I think a person who does physical activity regularly would also adapt to a healthier lifestyle and would less likely smoke. Maybe that's the reason why cancers are lesser in incidence among those who exercise, even if they smoked previously and are no longer smokers at present. So how might physical activity be linked to reduced cancer risk? One would be lowering levels of sex hormones. We know that estrogen and growth factors have been associated with cancer development in the breast and colon. Preventing high blood levels of insulin, which has been linked to cancer development and progression. Reducing inflammation. Improving immune system function. Altering the metabolism of bile acids and decreasing exposure of gastrointestinal tract to these suspected carcinogens. Reducing the time it takes for food to travel through the digestive system. It's obvious that if your transit time is faster, you have less exposure of your gastrointestinal tract to potential carcinogens. Also prevent obesity, which is a risk factor for many cancers. COPD. Now, among pulmonologists, although they give medications for chronic obstructive pulmonary disease, patients with moderate, severe, or severe COPD have shown to benefit from exercise training programs. The reason being, when a person with COPD exercise, their oxygen utilization capacity, which is one of the reasons or the goals for management of COPD, is increased. These benefits appear to wane after the program ends, but if exercise is maintained at home, the patient's status continues to remain above pre-rehab levels. Improvement in exercise tolerance and a reduction in dyspnea and fatigue was also noted. Coronary vascular heart disease. As we know, the major risk factors for coronary vascular heart disease would still be smoking, hypertension, and diabetes. And we have mentioned a while ago that this condition, specifically hypertension and diabetes, can be curbed or minimized or even controlled with physical activity and exercise. Now, high level of leisure time physical activity has a beneficial effect on cardiovascular health by reducing the overall risk incidence of coronary heart disease and stroke among men by 20 to 30%. Moderate level of occupational physical activity might reduce 10 to 20% risk of coronary vascular disease. So, some people might think, what type of activity, how frequent, and how intense the exercise. Bottom line still is, it's good to have a regimen, but you're still better off with some physical activity than no physical activity at all. Relative to normal weight, obesity class 1 and 3 has been associated with significantly higher costs of mortality. And if we look back to our prior presentation, it was noted that exercise reduces obesity. And obesity, as we know, is a risk factor not only for cancer, but for coronary vascular heart disease. Grade 1 obesity was not associated with higher mortality, suggesting that the excess mortality in obesity may be predominantly due to elevated mortality at higher BMI levels. So this table illustrates the BMI, or kilogram per meter squared, of individuals that are classified as class 2 and class 3. Hypertension. Among hypertensive individuals, habitual physical activity independent of risk factors lowers blood pressure and lowers the risk for mortality. Surprisingly, it has been found out that if a person is normotensive, his blood pressure doesn't lower with exercise. It is only found, or the lowering of blood pressure are only found among individuals who are hypertensive. Stroke. Exercise lowered the risk of stroke by 27%. Regular, moderately vigorous, or too vigorous self-reported physical activity is associated with reduced risk for stroke and transient ischemic attack in this large multiracial prospective cohort study. Osteoporosis. Now, there are two factors that would prevent osteoporosis among individuals who exercise. These are increased insulin growth factor 1, or somatomidin C, which increases bone mass, increases lean body mass, and IGF-1 is required for maintaining the normal interaction between osteoblast and osteoclast. Always remember that in osteoporosis, there is a predominance of osteoclastic activity, and there should be a balance between these two. Weight-bearing exercises, on the other hand, decreases sclerostin. The effect of sclerostin is decreased osteoblastic activity and increased by bed rest, and increases with age and diabetes among males more than females. So, sclerostin decreases osteoblastic activity, which is related to bone formation. It's a cell responsible for bone formation. Alzheimer's disease, executive function of the brain. There is reduced risk of developing Alzheimer's disease by approximately 40% among individuals who exercise, and physical activity during leisure time in old age was associated with lower risk of dementia-related mortality when compared to inactive individuals. Studies have shown also that the exercise groups had lower mean diffusivity. Mean diffusivity depicts degenerative or inflammatory processes and increased free radical diffusion into neuronal cells. If you have increased mean diffusibility, there is an increased tendency for you to have a degenerative cortical disease. Now, it is mentioned here that exercise lowers mean diffusivity. Regular physical activity in children and adults have been shown to lead to higher academic performance, and acute physical exercise enhances executive function. How about our immune response? Better fitness also heightens antibody responses to vaccines against influenza and other illnesses. This study was done before COVID, and it shows simply that if you exercise, your immune response to any form of disease process is increased or heightened. High frequency, intensity of training enhance vaccine responses in elite athletes through more pronounced increased specific T cells and neutralizing antibodies. How about exercise and COVID-19? So more recent studies showed that patients with COVID-19 who were consistently inactive had greater risk of hospitalization, admission to the intensive care unit, and death. OR here stands for odds ratio, and this is a simplified table of the previous text. If you notice, persons meeting physical activity guidelines and those compared to persons performing some physical activity guidelines would have lower odds ratio. So, with hospitalization, admission, and death, okay? So, the higher your odds ratio or the farther you are from one, this means that there is a greater association with exposure and outcome. So, patients who meet physical activity guidelines would have odds ratio of greater than 1, and those performing some physical activity would have lower odds ratio. Consistently meeting physical activity guidelines was strongly associated with reduced risk for severe COVID-19 outcomes among infected adults. We recommend effort to promote physical activity be prioritized by public health agencies and incorporated into routine medical care. Relationship between BMI and COVID-19 infection. Compared to normal weight individuals, the adjusted odds ratio of severe COVID in overweight versus obese individuals was a bit lower, and that those obese individuals would have higher odds ratio. And this is a simplified table of the same. So overweight individuals would have 1.26 and 1.9, and you would have higher odds ratio among obese individuals at 1.49 and 1.82 for severe COVID and mortality from COVID. Relationship between BMI and speed of walking to COVID-19 infection. Compared to those with a brisk walking pace, OR, or the odds ratio for severe in COVID-19 for steady and average workers would be 1.13, and for slow walkers that would be 1.8. Slow walking would be less than 3 miles per hour, and steady or average walking would be between 3 to 5 miles per hour. Now for COVID mortality, it's the same. Steady or average walkers would have lower odds ratio compared to slow walkers, which would have 1.83. Now this is again a simplified table of what we just stated. If you notice the steady average and speed and slow speed, comparing severe and mortality from COVID-19, those with slower speeds would have higher odds ratio. Relationship between muscle strength to COVID-19 infection severity. This study results show that the higher the grip strength of an individual has a lower risk for COVID-19 hospitalization. And also age have been a risk factor, as you have been told and informed. The higher or the older the individual, the odds ratio is also higher. And with obesity, again, the odds ratio is higher. So the tendency for having severe COVID or dying from COVID is higher if a person is older or heavier. So let us go now to the basic of exercise. What type of exercise should I do to develop fitness? How much activity do I need to stay healthy? How often should I exercise? And how long should each session be? We make use of a mnemonic FITT when making an exercise prescription. How often would mean frequency. How hard, intensity. How long, time or duration. And what kind, type of exercise. So exercise intensity is described as either light, moderate, or vigorous. For those who are taking the board exams, this is a regular question that the examiners ask. Light, meaning can talk and sing while exercising. Moderate, can talk but can't sing. Vigorous, difficulty of talking when exercising. METs, or the equivalent of kilocalories per kilogram hour, is of course higher in vigorous exercise as compared to light exercise. RPE means rate of perceived exertion. It is 9 to 11 for light, 12 to 13 for moderate, and 14 to 17 for vigorous. And your heart rate maximum, which is 220 minus your age, that's how it is calculated, is highest for vigorous and lowest, of course, for light. So what do we do as a doctor when our patient comes in for an exercise prescription? So this data, or this study, has been mentioned in our guidebook. And we can stratify the patient as either patients who participate in regular exercise, and those who have not exercised at all. For those who participate in regular exercise and are asymptomatic, they don't need to be medically cleared. Before, in the 2011 guidelines, they made mention that if you are 40 years old or older, you need, irrespective of your status, you need to have medical clearance. Now, among patients who participate in regular exercise and who are asymptomatic with no known cardiovascular, metabolic, or renal disease, no medical clearance is needed. They may participate in moderate to vigorous intensity exercise. How about those individuals who don't participate in regular exercise, who are asymptomatic with no known cardiovascular, metabolic, or renal disease? Again, no medical clearance is needed, but you have to downgrade the intensity of their exercises from light to moderate. Now, for those individuals who participate in regular exercise, are asymptomatic, but with known cardiovascular, metabolic, or renal disease, they don't need medical clearance for as long as the exercise that they engage in is at most moderate in intensity. Medical clearance is not needed with gradual progression to vigorous intensity if one remains asymptomatic and has been medically cleared for the last 12 months. Medical clearance is required only if signs and symptoms occur. For those who don't participate in regular exercise, are asymptomatic but with a history of known cardiovascular, metabolic, or renal disease, medical clearance is required. If cleared, they only start with light to moderate exercise and progress to higher intensity based on the American College of Sports Medicine guidelines. Now, how about if an individual participates in regular exercise but is symptomatic? If the patient is symptomatic regardless of known disease status, you discontinue exercise and seek medical clearance. If cleared, they may return to exercise regimen and may gradually progress. So, but for security reasons, I guess it's best to start in with the low intensity exercise. How about an individual who does not exercise at all and is symptomatic? Medical clearance is required, and if light to moderate exercise is recommended, the patient may progress to higher intensities, and if cleared, they can start with light to moderate exercise and then gradually progress based on ACSM. Now, in my practice, what I do is I stratify them after they've done their stress testing. I think the cardiologists are in a much better position to advise us what ceiling activity we should prescribe to the patient who are symptomatic and also have concomitant comorbidities. So what are the components of physical fitness? You have muscular training, joint flexibility training, cardiorespiratory endurance, and aerobic exercise. ACSM, or the American College of Sports Medicine overall recommendation is we prescribe regular physical activity that is equal to or more than 150 minutes per week. Active adults and older adults should engage in 150 to 300 minutes of moderate intensity exercise or 75 minutes to 150 minutes per week of vigorous intensity exercise. 2 or more days a week should also be dedicated to strengthening exercises. This is an example of the new American College of Sports Medicine FIT recommendation for hypertensive individuals. So you have frequency, intensity, time, and type. If you look at the table closely, it says there the frequency would be 2 to 3 sessions per a week. Okay. Neuromotor, on the other hand, there would be exercises that would promote balance. This is best exemplified by Tai Chi and your balance exercises. And flexibility would be stretching. Now, for cardiorespiratory exercise, 30 to 60 minutes of moderate intensity exercise 5 times a week is acceptable. 20 to 60 minute vigorous intensity exercise 3 times a week is also acceptable. Now, 2 years ago, most of the authorities have advised us that the activity should not be less than 10 minutes in duration. But this has been modified recently in the current guidelines. So does the 10-minute really cast in stone? No, it is not. So you can modify your moderate to vigorous physical activity for 90 minutes all at once, 30 minutes 3 times a day, 15 minutes 6 times a day, or 10 minutes 9 times a day. Okay? Studies have shown that even if you do 10 minutes 3 times a day or 5 minutes 3 times a day, it doesn't make any difference. So I guess the bottom line would be the comfort and the convenience of time that the patient is able to engage in this physical activity. The more important thing is, for me, they should space or equally distribute the schedule during the week and to accumulate a minimum of 150 minutes per week. So this is just a summary of what the expert recommend when a person needs to engage in physical activity. So children should do every day for 60 minutes of moderate to vigorous. This usually comes out in the exam. Adults 18 to 64 years old, weekly 150 minutes, moderate or 75 vigorous. Older adults, 150 minutes of moderate or 75 minutes of vigorous. Now, 3 of those days should include muscle and bone strengthening for all 3 groups, 2 days for adults, and 2 days for the older groups. Types would be walking, gymnastics, jump rope, soccer, free play for children, walking, running, biking, basketball for adults, walking, gardening, aqua aerobics for the elderly. Now, resistance training for strengthening of the muscles, we should train major muscle groups 2 to 3 times each week using a variety of exercise. We get a 10 repetitions maximum. When you say 10 repetitions maximum, we get a weight, then we move our limb or body part for 10 repetitions without doing any trick motions or without exerting extreme effort. That is your 10 repetitions maximum. If you lift a weight and then you already are grimacing or doing trick motions just to lift the weight, that's not your 10 repetitions maximum. So 10 repetitions maximum should be made for 10 repetitions with the same arc of movement and the same effort. Okay? Now, 2 to 4 sets would improve strength. 18 to 12 reps would improve strength and power. Avoid working muscles for 2 consecutive days and give 48 hours interval in training muscle groups. Flexibility exercise should be done 2 to 3 days each week. Stretching should be held for about 10 to 30 seconds to the point of tightness or slight discomfort. There should be no pain. Repeat the stretch 2 to 4 times, accumulating 60 seconds per stretch. So 2 to 3 times a day, 10 to 30 seconds per stretch, to a cumulative value of 60 seconds for each muscle group. It is best to exercise when the muscles is warm. So you encourage the patient to do limbering exercises before they start their stretching. It would also be good to do stretches before an aerobic exercise and during cool down. Neuromotor exercises or functional fitness training can be done 2 to 3 days per week for 20 to 30 minutes. Motor skills exercises would promote balance, agility, coordination, and gait. Proprioceptive exercises like your balance boards and multifaceted activities like Tai Chi or yoga improves physical function and has also prevented falls. So these are the points that we have clarified so far. Exercise is beneficial, but it is still possible for adults to develop heart problems. So you have always to be vigilant when making an exercise prescription. Sedentary behavior has been shown to be a health risk in itself. Adequate amount of physical activity and lifestyle change should go hand in hand. So it doesn't mean that you exercise but you are not so cautious about what you take in or you still smoke. Everything is canceled out. Now let us take certain factors about the current pandemic and what are the exercises that can be allowed and should minimize our exposure to infection. Now, the lowest risk is seen in playing tennis, for instance, okay? Moderate risk if you play golf. Again, we should still exercise physical distancing and make use of barriers like masks. Okay, and moderate risk if you swim in a public pool. Now, I, for instance, do swimming, but when I swim, I usually am alone, so that makes my activity low risk kind of physical activity. Now, team sports, I wouldn't encourage it because you won't really have any control about exposure to other individuals, and contact sports would have close proximity between players. And the highest risk would be, of course, going to gatherings with a lot of individuals or people attending. CDC guidelines in using gyms and fitness centers. Okay, you can reserve a time slot, virtual aerobics or fitness classes. Check if the staff uses PPE. Bring personal towel and sanitizers. Avoid using shower and changing areas. Prefer open facilities. There are gyms now open here in Bacolod, but I would advise my clients to go to gyms where the windows are open and air conditioning is, even if it's open, the windows are still open so that there will be adequate ventilation and that the air that is circulation is not stagnant. Again, physical distancing, maintain at least 6 feet of separation, and of course, for courtesy, clean as you go, meaning wipe the equipment that you use, place a disinfectant, and also hand washing and sanitize before adjusting your mask or wiping your face. Interagency Task Force sports guidelines, I think this still holds true at the moment. Sports that are allowed are walking, jogging, things that you can do alone, biking, golf, swimming, tennis, badminton, equestrian sports, range shooting, skateboarding, and practice conditioning. Again, something that you can do alone. So what do we do after our patient has been de-isolated or had been cleared from COVID-19 infection? Now, it is essential that we monitor the oxygen saturation of our patient. We know for a fact that if a patient is infected with COVID, they would have inflammatory responses in their lung, and to the point sometimes that it would cause some form of fibrosis or scarring. And this would really or significantly diminish their capacity to have a good or adequate air exchange. So what I do among my patients is I make them invest in a pulse oximeter, and I tell them to exercise with a pulse oximeter always on them and monitor oxygen saturation during exercise. Now, most exercise protocols would mention that we should monitor the oxygen saturation and not allow it to go lower than 88%. Okay? But most of our pulmonologists here in Bacolod, and I'm sure also in your locality, would make it best, I would suggest that the O2 saturation of the patient would still be between the range of 92 to 94. As we know, the normal PO2 would be 96 to 100%. Okay? Now, I took up some literature and I verified the accuracy of pulse oximeter as opposed to ABG, and it has been shown that the oxygen saturation with the central arterial blood gas correlated well with pulse oximeter. So this is a busy slide. Individuals with mild symptoms who are not hospitalized during the symptomatic period are made to rest with no exercise. When you say no exercise, no physical exertion beyond that of the usual activities of daily living. You can make them go around the house with the oximeter on and then just tell them to monitor their oxygen saturation. But they still have to move about, okay? Then after 2 weeks of convalescence, without resumption of exercise or after symptom resolution, they are usually worked up with high sensitivity troponin, 12-lead EKG, 2-dimensional echocardiogram, and consider additional symptom-guided testing. If it is normal, then you can have slow resumption to activity. Now, if their high sensitivity troponin is high or there is an abnormal cardiac study, then you might be dealing with myocarditis, so they have to be referred to a cardiologist, and then return to play guidelines are to be observed. RTP, or return to play guidelines. Now, if there is significant symptom and if the patient is hospitalized, during hospitalization, I think most of our colleagues would monitor high sensitivity troponin and cardiac imaging also to check if there is any cardiac involvement apart from the pulmonary problem. If this is normal, the patient is allowed to rest and recover for about 2 weeks, and then they are gradually enrolled again to the fitness program. Okay? Now, but if their parameters are high, then again, they are worked up for myocarditis, and return to play criteria or algorithm is followed. So what does this return to play algorithm mean? Okay, if a patient, you just have to follow this slide. If the patient is COVID-19 positive, okay, then you have temporary restriction from moderate intensity exercise until test is confirmed. If they are negative, then you can clear them for participation. If the COVID-19 test is positive, then you have continued restriction from moderate intensity exercise to less than moderate intensity exercise for 7 days. If they have no cardiac symptoms, then you can clear them for participation. But if they have cardiac symptoms, you have to continue restriction from exercise and monitor. Medical assessment with history and physical examination, and consider ECG and troponin are usually done, and we have to take note of COVID red flags, namely cardiac symptoms or congestion, pericardial rub and signs of heart failure, more prominent CVP, and ECG waves that are indicative of cardiac pathology. And of course, they have to be referred to a cardiologist. Now, this is a busy slide again, but just look at the table, and then you will be given these slides anyway. If a patient has had cardiac symptoms, okay, so initially we will do a 12-lead EKG and a high sensitivity troponin, and then a transthoracic echocardiogram. Now, you can have all of these red flags: left ventricular dysfunction, right ventricular dysfunction, and pericardial disease. Now, after the 2D echo is done and you have a normal transthoracic echo and a normal high sensitivity troponin and normal ECG, you can permit the patient to return to play with a graded intensity, meaning you start with a low impact, then maybe moderate impact before going to vigorous. Now, if you have an ongoing clinical concern, you might ask, or the cardiologist might want to do a cardiac magnetic resonance. And the gold standard for this is your T1 and T2. Was this MRI, your extracellular volume and late gadolinium enhancement. And when these tests are positive, then you have to do some secondary imaging if necessary. So computed tomography, angiography to check for lung pathology, stress echocardiography, and cardiopulmonary exercise testing, and nuclear and PET scan. So this was a paper that I saw, and then when they interviewed several physicians, they made mention, or they made the physicians answer a questionnaire as to what was their basis for return to play screening. And surprisingly, a large percentage only relied on symptoms. About 13% relied on symptoms plus ECG, and down the line, if you notice, the tests become more advanced. But most of those rely on symptoms. So I guess the bottom line in this case is, if you're in doubt, refer the patient to a cardiologist. I think they're better off in managing cases with cardiac symptoms. I think this will be my last slide. And for some parting words, as leaders in the community, I think we should lead by example. We should practice what we preach, live by the steps of your feet, and not by the words of your mouth. Thank you, and good afternoon.
Lifestyle medicine for COVID-19 and NCD care, a wake-up call.
Our gut is home to trillions of living microorganisms. In order to live, multiply, and perform their functions, they need to be fed sufficiently. Or else, they'll look for other sources of food within our body, which will eventually make us sick. Fruits and vegetables contain prebiotics, such as fructooligosaccharides, the right food for our gut bacteria. However, proper amount may not be acquired through natural food only. Hence, supplementation is needed too. Foligo is an all-purpose prebiotic powder that can be added to commonly consumed food and drinks, hot or cold. Each sachet contains significant amount of pure and highly concentrated fructooligosaccharides for prebiotic supplementation. Fructooligosaccharides are generally recognized as safe and has been proven to promote growth of beneficial microbes in our gut, resulting to healthy digestion, absorption, and elimination of food. Additionally, it enhances production of metabolites that are beneficial not only to the gastrointestinal tract, but also to distant organs and body systems. A well-fed gut will also improve immunity and decrease the risk of allergy, reducing the overall risk for a wide array of chronic diseases. Feed your gut with Foligo.